All right, hi everyone. Thank you so much for having me here today. I'm really glad to be joining you. I am in the frozen Northland of Minnesota, so that's where I am on a sunny day that we finally are getting. So, very good mood and very happy to be presenting this information to you. It's been a delight to get to put some of this work together in supporting migratory and seasonal agriculture workers in preventive care and self-management. So we'll just keep moving forward here. You've already seen this bit about me. I've done some things. I am a person who has type 1 diabetes. I've had it for 28 years. So this is anything about diabetes is a really personal conversation for me, but I'm also coming from the patient perspective for talking to people that have diabetes, but also being talked at as a person with diabetes. So hopefully I will be able to share some in-depth insight with you today that's also research-based. So we've got a really interesting perspective there. And I've published a book recently about my experience with diabetes as well. And I work across the entire country with people that have chronic disease in a very unique system of primary care that is a virtual delivery. And of course, my pride and joy is that I teach indoor cycling classes. That is my stress management to be able to continue to do what I do on a daily basis. So nothing to disclose today. And our topics of interest, this is really the table of contents here. So I'm going to try to hit on all these different bullet points within the chronic care model. So diabetes dilemma, what scares us the most as patients, primarily removing that fear and frustration, opening the lines of communication, because it really is an art to be a speaker, but also an educator in anything that we might be doing in healthcare. I'm going to present the DAWN study to you. Some of you may have heard of this. This isn't brand new, but it's really interesting and it applies really well to our topics today of applying person-centered language. And within these topics, I'm going to talk about reframing self-blame, really hone in on this type of communication through optimistic coaching and what living with diabetes might be looking like deep down, where we don't really see that on the surface, and also some follow-up coaching ideas involving patients in self-care and the clinical challenge that I know that we are all going to be thinking about in the back of our minds, probably as I'm giving you some suggestions in communication. And these will fulfill our 3 learning objectives below. So let's keep on moving forward here. So within this chronic care model, there are 6 of them to promote self-efficacy, but there's 2 of them that I really focus on in self-management support and decision support. So I really want to be able to inspire people to feel like they are capable of doing something well for themselves with the education that we are capable of providing. The perception and confidence, it's influenced by these pillars of diabetes. So glucose testing and medications, nutrition and exercise, but also brain, mental, and emotional health are part of this that sometimes can be a bit faded in between how much work we have to spend on just testing and medication management. But also within the chronic care model, we've got this written that individuals must assume an active role in their care. So we want to pull them in and give some kind of inspiration as to why you should help us help you. So within the depth of diabetes, the things that can help clinicians understand a person is knowing, of course, diabetes distress can be deep down with this isolation, and distrust can come from that, distrusting the people that are actually trying to help you. And so depression is really high in diabetes, anxiety is really high in diabetes, and this isn't by type 1, type 2, even pre-diabetes, we are going to see this. The obsession with control and perfectionism and self-worth tied to data, I see this quite a bit in type 1, but it can also happen in type 2 diabetes. And I see this most frequently when people get really caught up in certain types of nutrition programs that they might be seeking out. And the sense of failure can be there if there's a lot of pressure put on for something like weight loss, putting it on themselves at the same time. And then there's the fear and uncertainty. The fear and uncertainty of what's going to happen to my body and how am I going to prevent these complications. If there's a lot of focus that goes into complications all the time, that doesn't necessarily encourage someone to get healthy because fear gets in the way. So attention is turning towards our language and tone within the standards of medical care in diabetes. Really, every patient has a story. They're all very unique, and we can get really good at understanding those things quickly when we focus on communication. The diabetes dilemma, the consequences of pessimism and hypercriticism and comparing ourselves to others, this can actually cause this decline in physical and mental health where we think we're helping them be more self-aware of their condition, but it can actually lead to some kind of pessimistic thinking. So high rates of depression, the anxiety and the burnout, that's the depth of diabetes. And this can actually spin into a disordered relationship with food, which so many people with diabetes have. We're going to find research that gives us percentages as to how common a eating disorder is, but the disordered relationship with food is incredibly common because we actually have to teach people how to count everything, how to be so highly aware that it really is easy to focus on food for other reasons other than nourishment. And that can be a disordered eating practice. So there again is another reason why our communication can be so important. Medication avoidance and isolation from not being able to understand what we're trying to learn or what we as professionals are trying to teach. So negative language drives poor outcomes. So the undertones that we might be using as we're trying to discuss these topics with people, the word diabetic comes up a lot. And I am someone who does not like to be identified as a disease. I prefer to say I'm someone that has it, that I live with type 1, I have type 1, I'm Lauren, I'm not a diabetic. So that's kind of some language I would encourage everyone to really think about. Even if it seems like patients are not sensitive to the term diabetic, I really want to encourage people not to call themselves, I'm diabetic, diabetic this, diabetic that. It isn't who you are. You're a person first, and having diabetes is a partnership. So diabetic food, diabetic education, you're a diabetic. These are labels that can attach and they can end up feeling a bit like you're a person, you're diabetic first and a person second. So just a little twist in the tongue there could actually change somebody's entire perception of what's going on, that they are actually in control of this. So threats of complications, you are going to lose your vision. Even as we might be seeing something on paper that's looking like they may be going in this direction, giving this impression to someone can raise that fear, and that fear can lock them up into actually taking action, into doing anything for themselves because they may be thinking it's too late. Non-compliant and non-adherent, I know we use this language in charting, but to keep that in a closed space so that the patient isn't the one that feels like they're doing something wrong or doing something bad, because they may actually just not understand what they're supposed to be doing or the directive that they've been given. Same as unmotivated and unwilling, the term poorly controlled. I'm actually quite sensitive to that one because I find that a lot of people in questioning find that they didn't really understand what it took, where their blood sugars were supposed to be at certain times of the day and what they should be shooting for, because they didn't really get thorough education on that. Suffering and afflicted, I can see this in literature. Patients themselves use terms like sad and sucks a lot, and I try really hard to reframe their conversations about that, and I'll show you how I do that later. And also the big one for me as a dietitian is carbs are bad. I spend every single day reframing how people think about carbohydrates and what they actually mean and what they actually do for the body and how they're not all equal. So that's a big one where there's a lot of teaching moments here, negative undertones. And so there are opportunities for us as educators to incredibly improve someone's outlook on their health. Okay, so what scares us the most? Certainly going low, that hypoglycemia and the unpredictability of it, of our health in general, and feeling helpless to be able to improve or change anything. So we might be lonely in our decisions, thinking nobody really understands us, which is the misunderstood portion of that. Feeling misunderstood in your own home could happen, and also feeling judged by either healthcare professionals or the public in general, just because we have presented with something like diabetes. And what this can lead a person to do is potentially have additional health problems just from stress and anxiety. Other diagnoses start to pop up. And then they may actually take action that is fueled by fear of perfectionism. And that can be something where they're seeking alternative care that may not be ideal from a practitioner's standpoint. But community engagement and support can be a really good thing. So they're seeking some kind of community support. It could be online, it could be in person. And this is a really good opportunity for clinic to clinic to have some local resources or to understand what they might be looking for when they go online and start looking at Instagram or Twitter, is to define where healthy and safe and inclusive and positive language sites might be for them, which is plenty of work in itself to be able to sift through that, but it's worth it if you at least have a few resources for them to turn to that are positive. So seeking alternative counseling. Inappropriate recommendations can come from this. I hear all sorts of things in the world of nutrition where I'm talking to a patient and I'm like, what did they tell you? And then we have to unlearn and relearn something to make sure that they're safe. So unreasonable measures can come from this, meaning particularly in type 1 diabetes or even just in blood work themselves, that they are being told to reach goals that aren't really reasonable for them, like A1C in particular. And then abandonment of responsibilities. When people are afraid and they feel misunderstood or judged, sometimes they just say phooey with it. I can't do this anymore because I don't understand and no one is really seeing me. So from the patient and professional perspective, we agree on the place we want to go, but we have alternate ideas on how to get there. So how can we remove that fear and frustration and bring our worlds together? So inviting conversation, we're getting to the root of the problem as a team. Active listening, asking questions, and really digging in. So shared decision making comes through this between patient and professional, prioritizing and pooling resources, finding out what do they really need right now, that also aligns with the things that we need to be teaching and explaining. And it helps to lighten the burden with education. What can we use right now for this person to feel like they can do something, that they can get from point A to even B, even if it's a little step? We can help to remove some of that fear by making it look possible. So the question, how is diabetes affecting your daily life, is such an important question. It seems so small, but we do have some research that shows that a lot of patients aren't really being asked how their daily life is being affected. What this can do is identify barriers, but what it also can do is a patient can get really vulnerable in that moment. So as practitioners, be ready for that. There's some healthcare in ourselves when it comes to starting to get somewhere in communication with patients, meaning we may need to establish some boundaries for ourselves, to take some deep breaths. When you start to really get somewhere with someone, they will tell you all the things, and you will really understand where step one is and trying to help them move past this major barrier that they see that is preventing them from taking more control over their health. So barriers can lead us to put ourselves last too. For example, you may have someone who just is so concerned about their kids. They're so concerned about something going on in their house that they will not get enough sleep. They will have a super long commute. They will put everyone around them first, and they might test their blood sugar once a week just because they don't think of who they are at all. But the bottom line is, no one's going to take care of those problems without you. You are so important to this problem. So how can I convince you that you need to care about yourself? So placing responsibility by encouraging self-advocacy and finding that motivation for someone external from diabetes to say, this is what you really like. This is what you really care about. We need to focus on this thing and help keep you around and keep you healthy. So those patients need to be reminded that they matter. They deserve to give themselves care, love, and attention. And this may actually segue into something within your clinic where you find places that do volunteer breath work, volunteer yoga, and maybe even stretching, depending on the age of someone. There could be age appropriate resources there that could really help someone decide, I get to have 30 minutes a day to myself, whether it's on YouTube or in person locally, but take it and be really encouraging of this as a practitioner, is to say, you have to do these things for yourself. I'm writing you a prescription for self-care. So take that time, because no one else is going to get cared for without you. So you got to have you too. So opening lines of communication, building trust based on external challenges beyond disease management, just like the self-care conversation. So family, work, financial stress, these barriers unique to the individual are what you are trying to uncover, because they are so relative to the chronic condition. So healthcare practitioner, when you acknowledge the goals and those barriers, they lead to action items that the rest of the team can start to follow. So you're starting to acknowledge that something that might be along the lines of a dietitian, something that might be along the lines of more serious diabetes education that will always involve nutrition, but maybe it gets into the world of social work. So we start seeing these separate action items that can be compartmentalized into utilizing an entire clinical staff as to what they're really good at. So we start pooling our resources together around that patient. So there's our patient-centered patient-centered care, but in a very calculated way, where we have measures, we can see how it's going to formulate, and we can start putting our strongest people into action with that thing that they are good at, just because the patient decided. So what I want to talk about today, there's that question, how is diabetes affecting your life? The patient really sets the stage. And if we can start addressing those things one by one, we have an amazing insight into that person's life that we may not have had to begin with if we had just gone in with clinical standards and been 1, 2, 3, 4, this is how we're going to do it every single time. We start with that question. So the clinical agenda, yes, there's critical values. It involves the physical exam and external referrals. Coordinated care is really what we're trying to do here. So motivation is internal, but external support is imperative. And that patient is really saying, please be somebody I can trust. And that's what opening a line of communication is. They're going to feel that you care about all these other external factors that are affecting diabetes, because the diabetes affects everything from head to toe, just like everything head to toe affects diabetes. So there isn't really a wrong way of doing this. It's more of realizing that whole person matters, and there's so much to this picture than just A1C or just glucose value. We start driving and inspiring self-efficacy from several different angles in this way. So diabetes attitude, wishes, and needs study. This is the DAWN study. This is the one I had mentioned. It's really interesting, and it isn't brand new, but it's gone along a series over time. So this is massive, over 16,000 individuals in 17 countries. And look at these numbers here. They've got people type 1, people type 2, the adult family members. So they brought their input to this particular study too, about what do patients want? What do they need? How are we going to communicate better? And there are physicians that jumped in on this, specialists, nurses, dietitians, and then the family members here. So both the overall results from each component demonstrate that diabetes represents a significant burden for not just people with diabetes, but the family members, the healthcare practitioners, the society. The whole system is contributing quite possibly to this burden. It's not just the fact that they have diabetes, there's more to it. So healthcare practitioners in all these countries, they considered current healthcare and diabetes to be inadequate, with up to 1/3 of professionals indicating that they had not been given any formal diabetes training. Another reason to have a team, to be able to refer out, to know who you want to work with your patients with you. It will absolutely increase the success rate to have a team. So although psychosocial support was considered crucial, only about half of the healthcare practitioners indicated that they asked people with diabetes how it is affecting their lives. So there comes our question again, how is diabetes affecting your life? And the people with diabetes indicated that diabetes had a negative impact on all aspects. So relationships, family, friends, this high rate, 62%, it's difficult on physical health. And then 40% reported that medications negatively affected their ability to live a normal life. So there may be an opportunity for insulin education, pharmaceutical management. I see quite often that patients that have not had any conversations about nutrition, they're going to be on several different medications, perhaps even insulin at that time. And I ask them, have you ever met with a diabetes educator? Have you ever met with a dietitian? They say, no, but I've done my own research. I say, okay, tell me about that. And through that, I find all sorts of new areas of opportunity to talk about insulin resistance and the foods that help to reverse the resistance. How can food help you, your body, become more efficient and work with the insulin that it's still making? And this is a totally different perspective for patients to hear that, wow, my body can actually start working for itself. Yeah, it sure can. And we can eat our way there, but we have to learn how to do that. And that can help to contribute to this normalcy, but also we have to look at medications now. Maybe you don't need insulin anymore if we learn how to eat our way to becoming more insulin sensitive. So it's a really interesting conversation if we just start to pinpoint where are the negative pieces here and how can we turn this into something positive? Where is the education gap? So only 48% reported participating in diabetes self-management education, but then 81% who attended found it helpful. So this is great because diabetes self-management education, it involves nutrition. It involves stress management. It involves talking about barriers and anxiety and maybe depression. So we're getting really well-rounded with all of those deep deep-seated things that diabetes can affect. So the availability of patient-centered diabetes care and psychosocial support for active engagement was rated low. So only 24% reported that their healthcare practitioners asked how diabetes affected their lives. Here we go again. So many of the family members responded that they didn't know how to help. It was just, they wanted greater involvement. They needed the education too. They wanted to sit in. They wanted to understand all these things that are going on. And I can tell you, as somebody with diabetes, is that your mind is constantly running when you have to manage medications or your food, or you're thinking about how you feel. And that can be very isolating. So you don't want to talk about that because you don't think anybody will hear you or understand you if they don't also have diabetes, even if it's your family. So being able to express, like, it's okay, let's learn together, let's really talk about what's affecting you, it will bring everybody into the whole equation. And ethnic minority groups studied remain underserved and experience greater diabetes-related distress and burden. So blinking lights all over this study, right? There's all sorts of opportunities here. And I encourage you to look into the range of these studies too, just to get further insight. And it may spark some ideas, things that you can do within your own practice to hit some of these big blinking lights that might be affecting you the most. So applying person-centered language. This is what I am really interested in spreading the word on, is the idea of catching the thread to provide resources. So it's listening for negative self-talk to intervene. I know that we get it into our heads that there are things that we have to do when we talk with somebody. There's things that we have to hit, boxes that we have to check. But if you really get someone talking, you're getting your communication really good and thorough, is people are going to start just throwing things at you for you to realize these are areas of opportunity to talk about. And I call this threads. So that's coming up with the depth of diabetes. You might start hearing things like, I'm catching on to distress here. I'm catching on to anxiety here. I'm hearing you talk constantly about obsession with where your blood sugars are after you eat. What is this idea of self-worth tied to data? And there's where conversations can become very specific and very direct, and patients feel so heard when you pick up on these things. And this leads into what's optimistic coaching. So building upon that thread to establish more trust. It's super individualized. When you acknowledge these things, you call them out. It targets the root of what's really going on here, what might actually be the barrier to them testing their blood sugars more often, or starting to take their medications more frequently. What is actually the root of why you aren't able to do this? What's going on here? That's where you continue to talk to them, continue to listen, and pull on those threads. Get as many as you can to start to put them together. It's out of the box thinking for professionals. So I love this for diabetes educators because I think they're so capable of so many things, and dietitians as well. And I like challenging them. So if the patient themselves gives them so much to work with, it becomes no day is the same. No 2 days at the job are going to be the same when you become really good at optimistic coaching as a communicator. And it will build on an educator's personal strengths. It will also build on the patient's personal strengths. Challenges a skill set, and that deep questioning is what we're trying to do, getting deeper and deeper into the depth of diabetes for that patient to expose some of those barriers so that we can really work with it. So here's how to reframe self-blame. So here's the impact of words. Some of these phrases might be very familiar to you, and patients might be seeking something when they give you these threads. How do we turn them into something optimistic? So I can't lose weight. This is them expressing failure. How can we turn this into something positive? I hear you. What are we really thinking is the reason why you don't believe that you can lose weight? Why don't you believe it? So we're not acknowledging the failure, but we're trying to turn them into questioners themselves. Why do they think they're failures? Tell me more. I'm so bad with food. Of course, I hear this all the time, this distress about never doing anything right. In my consults, I hear patients just slam themselves over and over and over again about they're doing everything wrong. And I often ask, who gave you the idea that you're bad with food? Who gave you the idea that you're doing anything wrong? What's happening here? And that's where I find all sorts of things coming out about, well, I heard that this was bad and I shouldn't eat this, and I was told to do this, and I have to limit this, and I can't do this. And I hear all of these negative things, and I say, well, let's make food fun again, okay? So we can turn that into something positive. My parents are diabetic. I'm doomed. So this hopelessness, I'm not going to get anywhere because I have not seen it go well. This is a great opportunity to help turn somebody's entire frame of what it looks like to live with diabetes into something more positive. So how can we inspire hope here? Yes, your parents may have diabetes, and yes, you have diabetes, but what is the barrier here? Why do you think that you're doomed? What tells you that you're doomed? And then we get even deeper into that thread. Of course, my A1C is bad. Diabetes sucks. This is type 1. Also type 2, but certainly I get this in type 1 all the time. And what I call this is seeking confirmation. So there's language here that I never use. I never sympathize by saying, yes, diabetes does suck. I say, well, there are definitely going to be some tough days. I hear you. I get that. But how are we going to turn those tough days around? How do we make less tough days and more good days? So you put that question back on your patients, let them do the talking, and you're going to get all sorts of information that you can do something with. So what we perceive, we believe. You can inspire amazing things with these patients. I know that you want to, that we want them to believe in themselves. And the more that we communicate like this, the more that we're going to help them believe it. And it actually really inspires us too. We realize that we're doing something different here and we're doing something right. We're still working within the chronic care model, but we are being creative about it. And we are becoming exceptional communicators in the process, no matter the language barrier of someone. If language is not there, if English is not their first language, there are still ways to work within these parameters, consistently inspire hope, and consistently inspire that they can become more self-sufficient. So more on the optimistic coaching, and inspires self-efficacy and individual agency. So taking ownership really is what it's all about with diabetes, because we aren't with them 99% of the time. So they've got to believe that they can do something well. The goals identified by our patients, they help us direct the care, but them to prioritize the values. So that's what collaborative care really is if we ask, what do you want to do with your health in the next 6 months? What do you want to see change? They start to talk about this. We start to hear what their values are. Well, I want to lose 30 pounds, and I want to lose 30 pounds because I've got grandkids now, and I want to be able to chase them and get up and move. Okay, ding, ding, ding. We hear that that is your motivation. So now we can start directing some resources. It sounds like we need to talk about nutrition. What about the medications that you're taking? There's all sorts of things to review in that collaborative care so that we can give them hope, as to say, well, I'm going to help you get there, but we're going to keep reminding you that this is what you wanted and this is what you're going to do. Okay, so let's keep working at it. And that inspires them to say, okay, I'm ready to go. I'm ready to go. And at the same time, when we talk about nutrition, we want to always make that really attainable, very possible. That's something that I focus on, is making sure that the nutrition is realistic and it isn't a diet. So we aren't teaching people how to diet. We're teaching them how to eat, how to nourish their bodies from head to toe in a very holistic perspective. That really changes the conversation for people that think that they can't eat anything they want ever again. Is really an art to talking about nutrition in that way. But things like anti-inflammatory nutrition, certainly I come from a plant-based perspective, but really it's teaching people how to eat color. From food groups, again, vegetables and fruits, they're not the bad guys. Whole grains and beans are not bad guys. They actually contain a lot of fiber. So let's talk about nutrition in a more positive light. What helps you to reverse insulin resistance and what contributes to it? So there is a huge teaching moment from us directing the care, but them prioritizing their values. So from the patient perspective, our words and thoughts inspire action. Pain is a catalyst for change. I was listening to a sports psychologist who I really like, and he is an incredible reader of people. And he talks about pain being a catalyst for change. And that pain could be the minute someone's diagnosed with something. It might take a while for them to get there, but that thing that's hurting you is actually something you want to change. But we need to find the realistic measures, as in, here's what to go after first when it comes to reducing that pain. Transforming fear into wisdom. We're providing education, even if it's just a grocery list, if it's a place to get food, if it is something more creative on the order of physical activity. We're trying to reduce their fear of how to do something good for themselves into education. So now they're acquiring knowledge as to working with this on their own. And I always like to tell people, when you get this down, when you really understand this, you now have the responsibility to teach your family and your friends and anybody around you, because when they see you getting healthy, they're going to ask you what the heck you're doing. So you get to now be that inspiration to other people. And sometimes, or maybe more often than I see it, people are really excited about the idea of being able to sit up straight and talk about these good things that happen to them. Rewriting internal dialogue by building personal power. So every time we talk about something positive or we help somebody see that they can visualize themselves getting healthy, they start to rewrite their thinking, rewriting the dialogue of how they talk to themselves. All this pessimistic conversations about, I can't do this, I'll never get healthy, my A1C is so bad, I can't eat this. We want to rewrite that internal dialogue, and that will help them move from point A to point self-sufficiency. And determine your experiences with positive self-talk, the empowerment of, if you want to get healthy, you got to believe it. And I'm here with you. So we've got to build the power, help someone build this up, no matter where they're from, how old they are, whatever stage of diabetes they're at. There are ways to do this. And it's through being kind to yourself and realizing that you can do something, and something will positive will come from that. But we've got to figure out where that thing is. Optimistic coaching. So living with diabetes, our words enhance the lived experience, meaning as professionals. So what we're trying to do is build a bridge from patient to professional in empathy. And empathy is different from sympathy. Sympathy might have been something like, someone says diabetes sucks, and you say, yeah, I get that, I know it sucks. Well, empathy would be, I hear you, and I want to understand more about it. Can you help me walk in your shoes? Tell me what it's like to eat with you, no judgment. I want to see what you eat during the day, and then I can help to find out what we're missing. And discovering individual core values is motivation. So helping someone realize that, the idea of wanting to be able to run around with their grandkids, family, that's a core value. Trust and honesty, that is probably also a core value between patient and practitioner. People feel really motivated when we pull these things out, when they start to see it themselves, even on paper. And we're positive from the moment of diagnosis, and that is a patient's insight into what they have going on. So I've run a lot of teaching some classes for people that are newly diagnosed, and they often come in with fear, or they come in feeling super bummed, and they've already gotten an earful from their family or from somebody else about what diabetes is. So it's our job to talk about what diabetes is, but also what it's not. And it's not a death sentence, and it's not doom and gloom. We have to say, you can get healthy here, and you're going to see a dietitian who is going to talk about reversing insulin resistance. Do you know what insulin resistance is? All sorts of teaching moments there, and the insight as to what their body is capable of and what is positive to come. And what we're doing also is exchanging authority for knowledge. So what we don't want is for patients to feel like we're towering over them, that we're talking at them, that we're telling them, we're reading off of a list, and here's your handout, and see you later. We know it doesn't work. If it did, we'd have amazing outcomes in this country based on the things we've been doing for the last 40 years, but it's time to start adjusting some of these practices that we have. So the therapy, nutrition therapy is really what it's called, healing itself also. So exchanging authority for knowledge is a process of healing. It's helping somebody realize that they are learning more about their bodies than they had beforehand. And that is in our practice to be able to deliver. We can deliver this amazing knowledge that they never had to begin with. We want someone to believe that that is an opportunity. So there's an opportunity even within being diagnosed with diabetes to get healthy. So identifying knowledge gaps that a person agrees to prioritize. This is taking action. Even just yesterday, I talked to someone who said to me, I just don't know if I'm ready to do any of these things about my health, because I know where I am right now, and I'm really stressed, and I had to work with that. So it was a matter of saying, okay, well, here are all the things that you could do, but we're not going to do all of the things. We're only going to do a few of the things that you think are going to fit within your schedule right now, within who you are right now, because that's where we're going to start. That was a knowledge gap that we picked up on. So we're just going to start with a grocery list. If you already go to the grocery store, let's get really, really good at it. Get these foods in the house, and then we're going to figure out what we're going to do with them. So that was all we needed to do in that moment to build some trust, to build some understanding, versus it being, no, you need to do everything, and that's the end of it. This is what we're going to do this time. Can you take action on this? So you let that person start to build their power, let them build their ability, and also their trust and their relationship with you. Community health groups too, they're culturally crucial. Cooking classes, open forum discussions, even moderated QA. So within certain clinics, being able to bring people in and have open conversations, having a topic of the day, and thinking critical thinking, but also that partnership with, I'm not the only one here that wants to talk about this. That can be really great for people in a community to see. And certainly this can be in multiple languages. It can be culturally specific, just like with a cooking class, and it can be really simplified too. And if we just open up this conversation with people and we provide it, at least from a clinical perspective of, we'll have one of our dietitians there, we'll have a diabetes educator there, we'll have someone delivering QA even from afar like this, that can do wonders for people that may not have great access. So follow-up coaching, revisit these intentions. So the action items that you established initially, these are the things we're going to talk about today. They're, from identified knowledge gaps. Non-scale wins can be encouraged. So you're just wanting to talk to someone about their energy. So you don't have to step on the scale all the time, but think about feeling more energetic or less brain fog. Mental clarity are going to be non-scale wins. Your clothes getting looser. These are things that people can get excited about over time, because sometimes the scale is the thing that does not motivate us to do more for ourselves. We just get bummed. So non-scale wins are actually quite motivating. Revisiting the intentions of vitals and labs and biomarkers, glucose records. So we're still covering our clinical standards, even within the optimistic coaching, and reframing that self-blame. We're going to constantly need to revisit something like that, especially if we're continuing to pull out threads of coaching when someone is starting to talk more about what their barriers are on that given day, and the shared decision making. So we're totally fulfilling the clinical model here of patient-centered care, but we're being really creative and super conscious about it. And the patient is actually a bit in charge. And this is how we can track these outcomes and start seeing what we're really good at in a clinic and what the patients really value. So we're demonstrating that the team is listening. That's an emotional bond. That's how our patients are going to love us. Remind a patient who they can trust and lean into. That is us. We're the experts. They don't have to go to Instagram. They come to us. We want that to happen so that we know they're safe. Enhancing self-esteem and confidence to continue pursuing goals, that personal responsibility. That's the amazing thing when someone comes in and they find out that their A1C dropped like 2 percentages and they have lost 10 pounds. I mean, you're all going to cry. You're all going to feel so excited. And something I often hear about from patients is that this was so much easier than I thought it was going to be. And that's music to my ears, because then I realized that they let go of a lot of things they were holding on to that they didn't believe in themselves. So involving patients in self-care, this is something that I call as a prompt, this providing a pathway to self-efficacy, personal report of my priorities today, just sort of a cute acronym here. So how to get the most out of your appointment, this could potentially be a tool that you use on an intake. So when you're talking to patients, you give them some idea of what you expect, but they get a chance to tell you what they expect. My first bullet here, arrive early, not on time. I think this is really important for everyone to know, is that please be the person who contributes to an efficient day, because you all deserve it. Every practitioner in the clinic or even working virtually deserves timely conversations. And when you both agree on that, then the patient can start taking on some of this power as well, being organized. They want to take inventory of their supplies, things that you kind of need them to take the reins on, having a general idea of those last checkups. They get to set the agenda. You're asking them to be assertive and honest and direct. Please give us your questions. Your clinic is safe. You can express anything you want here. You can ask for referrals to services that we may not offer here. And please, if you do not understand what we're talking about, ask for a clearer explanation. And we're inviting them to make these things known to hopefully prevent some confusion. People can go on for years not understanding what an A1C actually is, because we're so used to just talking about it as A1C, and we forget that, hold on, the patient doesn't have any idea what this percentage actually means. They know where they're supposed to go, but they don't know what it is. So let's talk about that today. And patients may be asking for it at the same time. So you've got a conversation starter in a prompt like this. And so I want to be realistic. Even through all of this going on in the clinical challenges, time and resources, over and over and over again, I know time is a huge issue for everyone in a clinic, every practitioner. There are more patients than there are us. But where are the opportunities? So it may be training for all. How can we effectively communicate so that we are all on the same wavelength and we just operate a bit smoother throughout the day? That's something that is an ongoing conversation, certainly where I work in a large care team. But it's one of those things to build in monthly is, do we feel like we're communicating effectively? Do we feel like our patients are talking to us? What are they saying that they need? What are we working on here? So communication is not something that often gets a lot of attention, but I think it is at the forefront of what we do. And knowing your local and national resources. So if you realize that you need to meet a diet, you need some dietitian referrals, you need to be able to refer out to social work or to some community resources, is have this collection going on so that you've got your people that are going to contribute to the success of not just the clinic itself, but of the patient in general. And modernizing education, the delivery of education. I call this modernized education, modern approach to nutrition education. We've been doing a lot of things the exact same way just because it was trained a certain way a long time ago. And it's time for a lot of that to get an upgrade, particularly in my line of work. That's why I'm here talking to you all about communication as it relates to nutrition and diabetes health. So if it seems like you need an upgrade in your clinic, that's going to be your next priority. And scheduling. Here's the other thing that's a challenge, is that when people like you, they show up. So you're going to be even busier. So you can imagine, if you're good at your job, if you are doing something innovative in your clinic, you are just such great communicators at getting to those threads of what people really want and seeing outcomes, you're going to be smoking busy. So that's another reason to think, what do we really need here to be a successful practice so that we aren't drowning? And those are just those things in the back of your mind as you're starting to build in some new ideas, is that what if we're good at this? What if we really get somewhere here? What are we going to need if we're successful? So it's the same thing we're trying to teach with patients. It's, what do we do when we're doing really well versus how do we fix something that we're not doing right? So you're kind of thinking in a different frame here, just like with reframing our conversations with patients. So we've all got something really optimistic to talk about. So that will do it for me. I think that let me make sure I didn't miss a slide there. Oh, yep. So that will do it for the greater conversation here. Your time and attention. I know I moved through a lot real quick, but this leaves us 15 minutes on the nose for QA. Should I minimize my screen here, or do we want to keep everything up as it is?
We can keep it up.
Okay.
So we don't have any questions in the chat yet, Lauren, but there are a couple of comments just to share with you. Thank you for shedding the light, because these are some very real problems. That was really inspiring. I can't wait to share with my patients the power of positive self-talk and empathy and commitment. That was all great. So just a couple of comments. If anyone has any questions, please plug them into the chat. That way we can address them now.
Yeah, even if you have think of any scenarios that have been hard to navigate, that are worth bringing up, almost like a case study that we could talk about with the time that we have, that might be something valuable too. So yeah, there's a range of things within this conversation that we can talk about, if it's communication or optimistic coaching, what do you do if. So yeah, I'm willing to help with any of that.
Yeah. So one of the questions actually, Lauren, that came to my mind as you were talking, and that was a really great presentation. Thank you. I also love the idea of reframing and shifting your perspective. I do know that one of the challenges that many patients come across is finding themselves lacking time to make it to their appointments, or to remembering to take their medication, or eating balanced meals. So can you share any thoughts or tips that you might have on how to approach those kinds of scenarios?
Yeah, the first question I like to ask is, take me into your day. Where is the time constraint? So if someone's working super early hours or overnight hours, that's the first thing to understand is, what time do you wake up, and do you actually feel hungry when you wake up? So we're trying to reset their clock in a couple of different ways. If it comes to nutrition, certainly. Trying to find out, when are you eating right now? And I have a lot of people tell me that they're so busy that they don't even sense their hunger signals. And that's a really good reason as to why somebody might not be able to lose weight, is their metabolism is just never being honored. So we have to reset that clock. We need to get those hormones firing so that you feel hungry and you feel full at certain times. So what can we work with? What time do you eat now? And they're definitely going to be eating. We just have to figure out, what time of the day do you currently eat, and when is it most realistic in your schedule to have 15 minutes to eat? And that's going to also be another conversation about, now we need to find things for you to eat. They're going to be quick and easy and healthy. That's what we're going to do. And then agreeing with the patient, is this realistic? Consistently checking in, like, is this realistic what I'm saying to you? Are you in a position where you have to eat fast food during the day? Tell me which restaurants you're eating at, and I'll look at the menu, and I will help you find something off of that menu to serve you. However, it shouldn't be the main thing that we're eating. So we're still educating there, but we're working within their schedule, not ours. And that's how you get them to agree to realizing, like, I don't have an excuse. This is my time to own. This is my schedule. And that can also be one of those things where, like if metformin, for example, or any kind of medication that they need to be taking with food, is to say, okay, this medication is going to hurt you if you don't take it with food. It's not going to feel good. So we've got to get the food in at the time that you're taking that medication. Can we agree on that? So you're constantly checking back. Can we agree on that? Can we agree on that? Okay, great. So now we're going to find something for you to eat at that particular time. So we get them on a schedule. We get them on, working within their own calendar, whether it's 4 a.m. of a start or it's 11 p.m. at their start, whatever it may be. We have to be super honorable to their non-negotiable time, which is going to have to do with work. It's always work related, even commute related. So and then social work may be your next pull in if it comes to transportation or their access to something. Those can be things that you find out along the way of trying to figure out, how do we reset your clock so that you get the medications and you get the food in at the right time. Gosh, I think I gave you an earful there. Did that answer the general question?
Yeah, that was great. Yeah, and those are great talking points to kind of take back and address with the patients. And kind of going along with that, we did have a couple of questions and comments come in. Someone mentioned, yes, in talking about the farm worker population specifically, work schedules are long and often medication may not be carried, like the insulin. So they carry it in a cooler, but there are a lot of different barriers in that regard. Specifically a question, how would you best treat a 10-year-old diabetic who does not really understand the importance of keeping their diabetes under control?
So we're probably talking about type 1.
I'm assuming
type 1.
So.
Yeah. Because in the last couple of years, I think that the research came out that over the course of COVID, that type 2 diabetes for kids has skyrocketed. And actually, I think the rate of type 1 diagnoses since 2018 has gone up like 15%. So we're going to be busy if we're not already in the education realm. Is okay. So with the 10-year-old, well, it's going to be, do the parents understand how serious this is? The parents are really the ones to talk to, as the ones that are grocery shopping, as the ones that need to be overseeing the administration of medication, as the ones that are going to be able to say, no, we're not eating candy for dinner. The parents are the ones that have to step into that responsibility, because that 10-year-old is only 10. And the portion of being optimistic with a 10-year-old is to tell them, you can do what your friends do. You can join the team, you can play the sports, you can get active. There's nothing holding you back from doing that. That could also be one of those things where, when we find out that a 10-year-old refuses to be active, they don't want to do anything but watch TV or play video games. That's another conversation with the parents, is to establish those boundaries of a child with any child needs to be healthy and active, but a child with diabetes in particular needs to be healthy and active. So I've even said to parents at times, I'm sorry, you need to inspire your children to be healthy, and that is a good thing. So do you guys also want to get healthy? Because if the whole household needs to change their groceries, then we need to work together to support your child. And so sometimes you got to get a little tough with parents, but they love their kids. They just, I think they're afraid. I think there's some fear there. So you may actually really be pulling those threads with the parents on, what are you afraid of? Are you afraid to say no? Are you afraid that that you need to give them everything they want because you feel guilty that they have diabetes? So type 1 diabetes is not it's not bad. It's something that happened, and now we have to learn from it. And I tell you, I've used type 1 as my strength now that I understand how, but I didn't when I was a kid. So inspiring the education with the parents is really key. and seeing how tough you need to be with them. But with the kid, it's trying to be as positive as possible. You're going to grow up. You're going to do what you want to do. Do you have dreams? What do you want to be when you grow up? What do you want to do a year from now? Are you excited for for 8th grade? These are the things to get into with those kids. So optimistic coaching on whatever level you can with them.
Thank you. Yeah, and that also answered another question on how to kind of reach teens and tweens and maybe parents that feel very frustrated. And you did touch on that. Thank you for that.
That's a big conversation also.
Yeah.
I mean, it really is. I'm happy to, please send me emails if you have any further questions particular about type 1. I was that angry teenager, so I'm happy to talk about it. That's why I wrote my book. I wrote the book from the angry teenager perspective.
Yes, and then somebody else mentioned a lot of mental health issues with teens as well. Another question though, what about patients who work the night shift specifically? Can you talk about any strategies that you would maybe recommend for them to live a healthy lifestyle and not feel secluded due to their schedule?
Yes. I have worked in the last couple of years. I've seen a lot of patients that work night shifts, particularly like Amazon, even Walmart, and very challenging because it seems like their habits are they don't get enough sleep ever. They don't get enough sleep. And plus, everything's against the circadian rhythm. So metabolically, we're just looking at something that is totally unnatural. So I really hope that anyone that works night shifts are planning to not be there forever. Although some people, they get so used to doing it that the 10 years go by and they haven't really changed anything. But we also know, based on research, that people who work overnights have higher rates of diabetes. They're more likely to be overweight, more likely to have insomnia. So it's the same idea with, understanding what those challenges are and perhaps presenting these ideas to them when it's appropriate. Do you realize that your work and the timing of your shifts could be the very thing that you need to change to get ahead of your health? If it's absolutely non-negotiable or not even in the near future to change, then it's the same idea of when do you start your day? We've got to nourish you no matter what. So no matter what time of day that you are awake, we've got to figure out what is adequate for you. Vitamins, minerals, getting them a multivitamin, certainly getting them more background nutrition that they're not getting because they're not awake during the daylight hours. And then figuring out, what are you eating at work? What food is available to you? Do you work on your feet or are you sitting? When can we get some steps in? When can we get some sort of exercise? Again, you're inserting yourself into their day. And if they say they absolutely will not eat more than twice, then you try to maximize the nutrition at those 2 meals per day and have them commit to, I will eat at, let's see, right before they get on their shift, they'll eat in the middle of their shift. And then do you think maybe you could eat when you come home and before you go to sleep, because we've got to get more nourishment in. So no matter what hours people are awake, they can still eat vegetables. They can still eat fruit. They can still eat healthy, whole, earthy grains. They can still eat beans. High fiber nutrition can happen any time of the day. We just have to strategize with them. When are you willing to actually eat? And do you get hungry? Sometimes it starts out really small because people they've trained themselves just to not eat. So you find out what that starting point is, and maybe it's just an agreement of they will eat within 2 hours of waking up, and they will try to eat again 4 hours later. So you see how you're mapping out something for them. So it's a roadmap to good nutrition, and it's according to their time slot.
Great, thank you. And I think there's just one more question here real quick. And I think it's a good wrap up. You've already touched on it. What are some specific challenges or barriers we often see agricultural workers facing in connection to diabetes? And how would you approach those with patients? So I guess kind of like we mentioned, the barriers with, not having a place to store their insulin while at work, or maybe transportation issues, or maybe someone mentioned there's also language barriers with the parents. So maybe final tips or anything that you'd like to share.
Wow. So it seems like the common theme might be, so I guess what I would do within these barriers themselves, if they're really, they're consistent, it sounds like, is that these particular situations are consistent with insulin, or they're consistent with transportation, they're consistent with with being on time is it could come down to some of the fundamentals of diagnosis, some of the fundamentals of here's how we build in overcoming these barriers that we know you're going to see because of the work that you do. Here's what we know is going to happen. There are some companies out there that make particular containers to keep insulin cold in any situation. I would look at, I can't think of what they're called right now because I know that one of them I tried, you can't take through airport security because of what's in it. So there are certain types of containers that will help keep insulin cool, and they're specific for hot temperatures and for people that travel a lot. That might be something where you could partner with those companies and see about getting some free samples in the clinic, see if you guys like them and see if they actually work. And that might be one thing where when someone comes into your clinic as a new patient, you have some way of giving that out to them or getting some kind of free samples. I think that would be a great way to be able to partner. And also then within the community of when it comes to transportation, finding out, it's a hard question to answer because I think a lot of times you have to look at insurance. And if someone has ride share coverage or they can get vouchers through Uber, there can be all sorts of little creative ways there and things that I am slowly still finding out is capabilities of people to be able to get access to. Novo Nordisk may have some unique ways to do that. JDRF also, and the ADA, they may have some vouchers and things where they're not out in front on their website, but if you ask them what kind of vouchers they have for people in these particular situations, they may have resources for you, like the JDRF of Texas. The ADA is going to have their own advocacy service within your state, or any state that you're in is going to have their own advocacy service within the ADA and particularly the JDRF, maybe even beyond type 1 for people that have type 1 diabetes. But if you go to those sources, they may be able to help you locally in ways that I can't even imagine just because I don't have all those tools on hand. So hopefully that inspires a little bit of tips and tricks from the inside.
That was great. Thank you so much.